And this COVID situation has given us an extra layer of concern and trying to sort of work out how do we best support each other during this time, I think is really, really important. Now, I think I'm the next speaker actually, Angela, is that right? Oh, okay, I'll introduce myself. So I'm Carolina Weller and I lead the Wound Research Group at Monash University. And we were given some funds to do this work that I'm going to be describing to you today. As with everybody else, I think this year, this COVID element has given us a big spanner in the works. And as a result of that, the project that we had proposed to start, and I'll explain that a little bit more as we go through the program. But I would like to acknowledge that the funding that we have got from for this building capacity to optimise pressure injury prevention and surveillance across Monash Partner healthcare services, although there are only 4 for the initial stage. So can I just have the next slide, please, Victoria? I think you're driving today. Thank you so much. Okay, so as most of you will be aware, pressure injury is something that has been in our hospitals for many, many, many years. It was recently, not so recently, but updated recently, put into the standards, the quality standards as a standard 8. We're preventing and managing pressure injuries and prevention of this for people who are in not only ICU. I know today is probably more likely to be focused on ICU, but this was general, just to make sure that we're actually looking at effectively managing pressure injury when they do occur. So preventing and then managing. The problem is with a small piece of work that we did prior to putting this flagship program together, what we identified is that there are many challenges and barriers to accurate measurement of pressure injury. And this can be staging and understanding the different staging parts. One of the things that came through quite clearly for us, just in one particular health service site, was nurses were sometimes documenting stage 1 as, unstageable because they weren't sure what it actually was. So there are elements there that we do need to look at. So this inconsistent pressure injury management and assessment and even clinical coding is something that we need to look at a little bit more closely and get some input from each of the health services as to how we could actually do this better to ensure that our, the measurements and the comparisons between health services are more accurate. So this lacking, accuracy and reproducible measurement of pressure injury was sort of, if you like, the base and the foundation for our project. Next slide, please, Victoria. So the work that we're doing is actually in 2 stages, and I won't go through a lot because today is sort of a nice introduction to this is who we are, this is what we're doing, so that we can try and connect people right across Monash Partners and you get an idea of what's actually happening. Oh, thank you, Christine. Okay, so the first stage of this particular project, looking at prevention and surveillance, is to map and compare existing pressure injury data across these 4 Monash partner health services. So the Alfred, Cabrini, Monash and Peninsula. And we're doing this by looking at 3 different sources of data and anything else that people tell us that they use. Primarily so that we can, first of all, map what's actually being used across the services, and also then so that we can actually see, well, what are the differences, and because we know that there are some differences just anecdotally. We're doing this from a research perspective, so we've sort of got a better baseline now. And what we would like to do is develop and pilot a pressure injury data harmonisation approach, which is literally looking at what do people do, what's working for people in the health services, and perhaps what do we need to do differently to ensure that there are comparisons that are accurate and documentation that is accurate. And at the moment, we're going through this identification of pressure injury assessment tools, because some health services use different assessment tools. And we're actually looking a little bit further into what are some of the coding definitions and what are perhaps some of the discrepancies that we found in one site, and is this applicable right across the board? Next slide, please, Victoria. The second stage of the project is actually looking at, we want to identify the barriers and the enablers to this accurate pressure injury assessment, documentation and coding. And for this, it's more of a qualitative piece of work. The other piece of work is looking at the data and trying to link that data with a number of variables to see what we can do to try and improve that from a data linkage perspective. But this stage will be actually talking to the clinicians who are looking after people in the hospitals. And we're also going to be interviewing the clinical coders so that we can try and work out what is being done, what do we perhaps need to do differently, and how do we put support mechanisms into place for the workforce so that we can actually get this pressure injury prevention and surveillance at a sort of an equitable level. Now, ideally, what we'd like to do is establish and evaluate a pilot pressure injury clinical registry. But like many of you, our project has been set back by a number of months due to the fact that COVID came along and we haven't been able to sort of start the work that we had planned to start during this year. So it's going to take us a little bit longer. So we plan to do the pilot pressure injury clinical registry in the future, and it might be something that we'll need to get some extra funding to do. We may not be able to achieve that in this program. Next slide, please. So there are a number of papers that are out there. I've put two up specifically because I thought it was important for you to see. So one, looking at proning in the emergency department. So it's a little bit different to what's happening, and this has actually been taken from the US, and we know that the situation there is much more dire than it is here. But the basic I suppose the basic element of pressure injury prevention, looking after somebody in that prone position, is going to be very, very different. I mean, we know from our own clinical experience that a lot of times it's the heels and the buttocks, the sacrum, perhaps the hips that are quite, that will be affected. But in a prone position, we've actually got things to consider like the forehead, the chest, the pelvis, the chin, shoulders, genitalia, particularly for male patients, iliac crest and knees, rather than those sort of traditional elements of. Now, I'm not going to go through that lovely piece of work down there by Michelle that was published in the Wound Practice and Research, because she's actually going to be talking to you about this particular piece of work in probably 10 minutes, 15 minutes time. So there's another paper that I think is very worthwhile for you to, as a resource you might like to look at. Next slide, please. Okay, so I just wanted to thank you for listening, and I'm more than happy for you to put any questions that you have up in the chat forum of Zoom, and I'll be looking at those so that at the end we can actually talk to and answer, and I can sort of direct them to the people who have spoken in this particular seminar. And it'll go pretty quickly, so we'll try and be nice, and I was trying to be nice and short and sort of concise for you. Would like to acknowledge the funding that we received for this project, without which we probably wouldn't have been able to do it. So I will finish, and I will pass on now to Dr. Victoria Ten, who's my Senior Research Fellow, as well as getting the fellowship with Monash Partners. And she's going to be talking to you about specifics from the pressure injury and the COVID perspective. So thank you everybody for listening, and I'll pass you on to Victoria.
Thank you, Carolina and Angela, for introducing me, and thank you everyone for attending this webinar. As you may have been aware that on November 19th, we were celebrating the Worldwide Pressure Injury Prevention Day, and this seminar coincides with the activities and with the awareness raising for this day. And I would like to acknowledge funding that we have received from National Health NHMRC through Monash Partners. And I would like to discuss some basic, to provide some basic information on coronavirus and on acute respiratory distress syndrome and pressure injury prevention. And I will focus on the infographics that we have developed, because many nurses said that they would rather like some visual materials so that they always have a reminder of what to do. Can you please move to the next slide, Victoria? Thank you. So also it's novel. I don't need to introduce to you the coronavirus, and many of you are aware that most people have only mild respiratory symptoms, but older people and people with chronic illnesses may become critically ill and develop viral pneumonia and acute respiratory distress syndrome, which require admission to an intensive care unit. Next slide, Victoria. In general, patients with acute respiratory distress syndrome of any etiology with worsening hypoxemia require prone positioning. Prone positioning helps to improve respiratory mechanics, improve oxygenation, and offload the weight of the heart. Next slide, please. So intubated patients may remain in prone position up to 16 hours per day, alternating with 8 hours in supine position. Prone positioning increases the risk of developing hospital-acquired pressure injury, and this risk is much higher when compared to supine position. Repositioning of people in prone position is a labor-intensive task, and clinical experience reports that they need to involve up to 7 people to reposition the intubated patient. Next slide, please, Victoria. I have provided some statistical information for you from our colleagues from the Alfred Health, from the Australian and New Zealand Intensive Care Research Center. From February 27 until June 30, there were 204 patients admitted in intensive care units with a laboratory confirmed COVID-19. Their median age was 63 years, and 140 of them were males and 64 females. Some of them had comorbidities. I would like you to note that 119 out of 24 patients, which comprised 58%, required invasive ventilation, and 79 people required this ventilation on day 1, and the other patients required invasive ventilation by the end of the week. And 56 out of 204 admitted people required prone positioning. Next slide, please, Victoria. The length of stay in ICU patients not requiring invasive ventilation was 3 days. However, the median length of stay of invasively ventilated patients was 16 days. And some mechanically ventilated patients, both invasively and non-invasively, stayed in ICU for over 30 days, which creates a vicious circle because increased length of stay increases the length of hospital-acquired pressure injuries. Next slide, please. Thank you. As part of our work at Monash Partners, we have developed an infographic for pressure injury prevention of acute respiratory distress syndrome patients in prone position. We have reflected on why the prone position is required. We have described the main pressure points. Next slide, please, Victoria. And we have discussed the all required care points prior to proning at the time when patients proned and when they are repositioned back to supine position. We also included a warning about following. We have summarized the risk mitigation strategies to prevent acquiring infection by health professionals. We have submitted this article and the infographic to Frontiers in Medicine, and this article was accepted and will be in press soon. And we have also placed it in OSF repository. I have included the link. Victoria, can you please move one slide up? Yes. I have included you the link to this article, and you can read the article and the details there. And the main points that we have discussed here will be discussed by our colleagues from the Alfred Health, and also some research conducted in this field will be discussed by Michelle Barakat-Johnson from our Sydney partners, who will start her presentation right now. Thank you. And if you have any questions, can you please write them in chat box, and I will answer them in the end. Thank you.
Okay, I'd like to just quickly just say welcome, Michelle. Thank you so much for making the time to present the work, your valuable work, to us. And we very much look forward to hearing from you. So we'll just take that on. Thank you, Michelle. I'm sorry, Michelle, I can't hear you. I'm not quite sure whether you're
Michelle, you're on mute.
Oh, mute. Sorry. Sorry about that. Thanks.
I think that's the saying for 2020. You're on mute. Welcome.
Thanks so much, Carolina. Thanks, Victoria and Angela, for inviting me to speak today. So my name is Michelle Barakat-Johnson. I'm the Skin Integrity Lead for Sydney Local Health District. That has 4 hospitals and 5 community health centres. I'm a member of Sydney Health Partners, and I have a conjoint position with the University of Sydney. Next slide, please, Victoria. So just the next slide, please. Thank you. Just to give you a bit of scope of what Sydney Local Health District looks like, given we're in New South Wales. It's an urban setting with, as I mentioned before, 4 hospitals and 5 community health centres. It's got a population of 700,000 people, and the ages, the most common age bracket that we see are between 20 and 44 years. We have the largest critical care service in Australia, currently with 56 beds plus 16 beds specifically for COVID. We have the largest melanoma unit in the world, and we perform approximately 400,000 operations per year. And we see approximately 170,000 patients in emergency, where it's a public tertiary referral hospital. And we call it a quaternary hospital. So Royal Prince Alfred Hospital, which is one of our main hospitals. Next slide, please, Victoria. So when COVID hit, we really wanted to know, and we really had to think on our feet quite quickly, like many of us did. And we really wanted to know what adjuvant preventative strategies were out there, especially because we were proning patients. And like Carolina mentioned before, we're so used to looking at measures to prevent patients in a supine position. But when it came to proning, it wasn't something that we did all the time. So my colleagues, Professor Amit Geffen and Leah Pico, were just before COVID hit, we were looking at facial pressures for patients who lie in a prone position, those that are having back surgery. And we were kind of a bit slow with that research, but then when COVID hit, we decided to move this along quickly. And in parallel, we were developing a protocol for our critical care service and also looking at ways in which we can prevent pressure injuries from occurring. In our district, we had worked very hard over the past 5 years before COVID hit to reduce our incident rate, because we had had a high, we had an increase, a substantial increase in pressure injuries over a 5-year period. And we were just putting in these measures based on the guidelines, but it wasn't working. And then when we unpacked a bit more, we found that that we really need, that there were many things, and Carolina, you mentioned it before, people were reporting suspected deep tissue, or, unstageable suspected deep tissue as stage 1 and vice versa. So there were reporting issues, there were equipment issues, and a whole pile of other things. So when COVID hit, we really we wanted to maintain that level of pressure injury incidents that we had reduced and worked very hard to sustain. And we certainly didn't want patients who came in with COVID, who were in a prone position, to leave with a pressure injury. So I worked quite closely with Professor Amit Geffen and Leo Pico, and we wanted to test out some adjuvant dressings such as the Mepilex border, because we know that Mepilex border has had a lot of research behind it. It's in the guidelines. It's probably the most researched dressing in terms of pressure injury prevention. And we wanted to look at the forehead and chin, and the reason for that is because it has very little muscle mass to provide the blood supply, and there's a lot of pressure that's put on a patient if there's, if they don't have a pillow. So we looked at that, and we know that the anecdotal evidence does report facial pressure injuries in a prone position, and they do go quite deep. So it's not just superficial. When it occurs, it goes quite deep, just as like that photo that Victoria showed you. So we worked on a model, it's an adult human model, and we looked at the biomechanical performances of Mepilex border. We used a 10 by 10 and an oval 7 by 8 times 10 for the chin. And we used this computational model head to have a look at how, what the pressures are. And we compared it with a head that didn't have the Mepilex border dressings. First, we calculated the distributions of the effective stresses in the skin and subcutaneous fat tissues, and then we plotted the exposures of the skin, the fat tissues, to 2 relevant anatomical volumes of interest. And then we calculated the percentage reduction in that area bounded when the dressings have been applied with respect to no dressing case separately. So next slide, please, Victoria. So what we found is that without the dressings, there was a very high level of stress, or, the skin stress concentrations were actually very high at the forehead and the chin, respectively. And you can actually see on that figure there, the red indicating where the pressure is. And if you see in the second figure the first figure, the second model there, you can see the reduced amount of stress with the dressings. And the stress concentrations reduced quite substantially with the Mepilex border, by up to 80%. So 33% on the forehead and 80% on the chin when the dressings were applied prophylactically. And you can see the second figure showing that force and reduction of the force. And if we think about the Mepilex border dressing, it's a soft, thick dressing and it provides localized cushioning. We know there's a lot of research to indicate its ability to redistribute pressure. Its multi-layering effect also helps with absorbing any shear loads, which often we see, as you know, in a supine position, we see it in the sacrum and we see it in the occiput and the heels. When somebody lies in a prone position, you also see that on the forehead and the chin, the chest, the knees and the dorsum. So it has that ability to be able to cushion, and the multi-layered stiffness structure of the dressing does affect or is effective in absorbing those shear layers. So what's the other thing that I wanted to say on that? So really, and the other thing with this is we found that it actually also alleviated or wicked away the moisture to allow for any perspiration to evaporate. Certainly what we saw in our ICU is that a lot of patients were quite cellulitic, and they would perspire a lot. So having that had that ability to wick away the moisture. Next slide, please. So when we look at the evidence around prophylactic dressings and prone positioning, there's only a couple out there. There's a lot more for the dressing itself in a supine position, but there's only a couple in terms of prone position, again, because we haven't had to use it as often, and it's, if anything, it would be used in surgery. But what they indicate is that it's actually generally well tolerated, and it's been demonstrated to be an adjunct therapy or preventative strategy for patients in a prone position. There was a large, or relatively large, 100 surgical patients known as the BOSS trial, and they compared Mepilex border with Opsite FlexiFix, and what they found is that there was a marked difference between Mepilex border group and the Opsite FlexiFix, with significantly less pressure injuries in the Mepilex border group. The next slide, please. So these are the studies that have been done over a number of years on prophylactic dressings, and majority of it has been done with patients in a supine position on the sacrum and heels. And I suppose one of the authors that have published the most is Nick Santamaria, and he's had a number of RCTs in intensive care and has really demonstrated that effectiveness in pressure injury reduction. The recent border trial had a number of potential advantages because they tested the dressing in aged care individuals where patients were mostly incontinent and had incontinent of urine and feces. Now they found that the dressing had that ability to wick moisture, which is absolutely integral to allow for perspiration. And as I mentioned before, when we look at a prone patient, even though we're not looking at incontinence in terms of pressure injury management because they're in a prone position, certainly the perspiration is to be able to wick that is absolutely essential. There's been a number of other silicone dressings that have been tested, but they haven't had the rigor behind them as the Mepilex border. A recent pragmatic trial of 393 elderly patients that used Alleven Life resulted in reduction of sacral pressure injuries. And then there've been a number of quality improvement programs that have used Alleven Life, and they've also found a reduction of pressure injuries. For example, Salmon and his colleagues use that as part of a pressure injury program to help reduce the onset of sacral pressure injuries. So really important to know when we're looking at adjuvant strategies for prone lying patients. So the next slide. Thank you so much. So this is Kim, our clinical nurse educator in ICU. What we did, and working in parallel with my colleagues, Professor Amit Geffen, I then reached out to another colleague of mine, Professor Fiona Coyer, at the Royal Brisbane and the Queensland University of Technology, and we put a protocol together to apply prophylactic dressings. We made these proning packs. And we did them for ease of use in clinical practice. We had these dedicated packs. They were made for each prone positioning event, and each pack included quick instructions, as you can see there in dot points, on how and where to apply the dressings, and an anatomical placement of where the dressing should be and the type of dressings. We started out by drawing a silhouette of the body, and we marked out the areas. With Professor Amit and Leah, we actually used 10 by 10 on the forehead, and then the oval 7 by 8 times 10 for the chin. But I decided to change the oval only because I felt that we could cover more of the forehead just when I saw it in patients. We also tested the sizing on ourselves. We lie down on the bed and we adjusted it just to ensure that we covered the majority of that bone, you know, any area that had pressure where there was bone. And then we also consulted with the intensivist and the nurse manager, and we asked for their advice. It went through a number of iterations, and we consulted with a number of nurse educators. We also got our audiovisual and media and strategics relations to actually help. And so I started by myself making up the packs with the skin integrity wound lead, and then we got admin support. Now we have these packs ready to go if we get a spike in COVID again. And we communicated to the intensive unit via emails and educated the nurses. So next slide, please. And this is one of our patients that was in a prone position. That we were able to take a photo of it. The photo is a bit blurry because we had to take the photo outside. As you know, we can't all enter in, and it was hard to actually take a phone into the room. So as I think Victoria mentioned, that it takes a team of 7 people. Yep, it took a team of 5 nurses and 1 doctor to be able to turn this patient into a prone position. So it's not an easy task. It's also not an easy task to reposition a patient, and that's why we use those microshifts. We had this strict protocol of conducting the microshifts every hour. We also looked under the dressings every day as much as possible as we could. So we monitored the skin, and we also had a small silicone fluidized positioner. We used the neonatal for the forehead to stop any pressure on the forehead. We also molded that every 2 hours. And as a result of that initiative, we only patients who came in through that spike in COVID over a 2-month period, we only saw 4 pressure injuries, and they were related to an endotracheal tube and nasogastric tubes. So we were very, very fortunate. Next slide, please. So I'd like to thank a number of people who contributed to this work, and they're listed there. These are my colleagues, Professor Amit Geffen, Leah Pico, Professor Fiona Coyer, Rue, Kimberly, Kerry, Kathy, Thomas, and Annabelle. And thank you so much.
Thank you so much, Michelle. That's just so brilliant. It's just so nice to hear. And when you say you were lucky, I think you were lucky because you were prepared.
Thanks, Carolina. Yeah.
So anyway, we'll move on, and hopefully we have a little bit more time for discussion and people can ask you some questions. What I'd like to do now is introduce the team from Alfred. We've got Padraig and Grace, who will give a little bit of an overview of what's happened in their health service, and hopefully we can learn from them as well in the same ways we've learned from Michelle. So thank you very much, Alfred team.
Great. Hello, everybody. Padraig here. Thank you so much. We're delighted to be able to share some of our experience with you guys. Yeah.
My name is Grace, and Padraig and I are both clinical nurse consultants here at the Alfred in the ICU. We are a tertiary service. We are the state service for burns within Victoria and also for transplants. And we provide a specialty service in regards to ECMO and trauma patients predominantly.
We'll just start off putting it right at the forefront that we would like to specifically thank our bedside clinical nursing team, without whom none of this care is possible. So just to keep those in our mindset. We're also quite mindful that while we're in a positive space now in Australia, which we can all take a breath of, for many of us, we still have friends, family, colleagues who are, dealing with this as a reality, and it's very challenging, and we're certainly mindful of that as we present here.
We within the ICU experienced 2 waves of COVID in terms of patients coming in. The first wave really initially were patients who had acquired COVID overseas and were returned travellers, and the second wave was more about COVID being acquired locally. But we really noticed that the acuity with both patients were, or types of patients were severely acute, really, very complex, and really collectively we put in over 10,000 hours of COVID care.
Just before we go to the next slide, we're also quite mindful that for everybody, whether or not that's been involved in direct patient care or not, it's been a very tough year, and we just want to acknowledge that no matter whether you've looked after COVID patients directly or indirectly, everybody's contribution has mattered and everybody has been affected by this. So we'll go to the next slide now, thank you. And I'll just pause there for a second just to kind of deconstruct that image a little bit, and really to try and just give you a little bit of an idea of the mindset of what it's like to be, in that space. There's a lot of anxiety there, and it's potentially a lot of fear for oneself, for your family, for your community. It's quite a busy slide. There's a lot going on. Everybody there has a purpose. Everybody has a role. You're behind glass. It can take longer to get to you. It can take longer to get things. It's a hard place to be.
And we probably learned a lot. We really honed our skills and our practices between the 2 waves for us, and we really went back after each to look at where we could improve at each stage.
We might go to the next slide.
So there are a number of priorities that we considered key right from the beginning in terms of how we would manage our potential for pressure injuries with this patient group.
And what became obvious very quickly was the ability of staff to work in this environment, the ability of staff to deliver any care, particularly complex care. They needed to feel safe. So developing a structure and a system to make them feel safe was really, really important. And we'd like to acknowledge our senior leadership team here, right from our nursing unit manager and our ICU medical director, with the support of the organization. They really led a very clear engagement strategy so that all members of our leadership team had a uniform message and were able to deliver that to the bedside so that the staff felt they were acknowledged, they were listened to, and that we could hear feedback in real time and deliver collaborative solutions.
And we know that communication can be difficult within any intensive care unit at the best of times, let alone within a pandemic, and with high numbers of staff and nursing staff, to ensure that a continuous message was put forth was important, and we prioritised that.
We use lots of different strategies to help with that. Again, in the early phase, there was a huge amount of information, but not all of it was correct or helpful. So the source of truth, having communication platforms that we could own the message on, was really important. We also put a lot of effort into delivering processes, so breaking down aspects of complex care to essentially reduce the mental workload of the staff at the bed space.
Should we go to the next slide? Early on, we acknowledged that we would not get anywhere without a strong collaborative process, and we were lucky enough to have a great team that really pulled together to deliver care. One of the things that we were really concerned about, obviously with this complex security of patient, a number of them were being proned or on ECMO, and therefore we had to have an approach to ensure that we would ensure that pressure injury care was delivered appropriately. So we introduced the functional teams approach that involved our spotless team, our healthcare assistants, our physios, and our bedside nurses, and we would systematically turn our patients. We knew that if we didn't want COVID to affect how we delivered our care. We looked at how we reimagined how we would do all of our normal tasks at the bedside and what they would look like with a COVID focus naturally.
We'd like to acknowledge the support that we had from our wound care consultants within the organization, and the environment and some of the restrictions on the movement of staff within the organizations significantly impacted on lots of external people's ability to come to the intensive care. But we found ways to collaborate. Next slide, please.
And I suppose it wasn't just the short term that we were having to collaborate virtually. Our patients were staying for a long time. Some of our patients have stayed for over 100 days. And so this needed to be an ongoing, sustainable method for communicating.
And the slide there just speaks to, the multiple ways that we have used technology to support that collaboration with other teams, with other nursing members, with patients, with families. Next slide.
So these are just a couple of slides really that demonstrate the number of people required to undertake any procedure. On the right, that is us undertaking a prone manoeuvre. And on the left, I believe that is a trachea insertion. We know that the pressure injuries with these patients, they've got a high severity of illness and then consequently a higher mortality rate. And the ANZIC's data really sort of backs that up, that the pressure injuries with these patients does unfortunately lead to a high mortality. And we were very cognizant of that from the beginning.
So we'll go to the next slide there. And so we actively undertook to make sure that our routine care continued, and messaging that very strongly and supporting our bedside teams to continue to deliver all that routine care with a strong focus on that pressure injury prevention.
And a lot of it really stemmed to education, strong education at the bedside to ensure that everything was in place to try and prevent these injuries where we could.
We'll go to the next slide. We already had a significant simulation program in place, which we actively engage with to deliver, complex care. And we utilize this extensively during this period of time to continue to prepare and train staff to deliver this complex care in a safe way, and so that we could also reduce that mental burden for when they were having to do that in such a challenging environment.
And we know that the only way really to build capacity and to see it continue is by having really strong buy-in from all of our sort of team. And so we had strong allied health buy-in and medical and nursing leadership and buy-in. So it really worked well in our group.
And really just highlighting the importance of your senior stakeholders, so your senior nursing team, your senior medical team, hands-on in the room, delivering support, delivering care. So delivering that message to staff in real time is tremendously powerful. We'll go to the next slide. Thank you. This is just an example of one of the many workflows and guidelines that we developed or tailored during the period of time. And again, the whole idea was to reduce that mental workload, to allow staff a framework in which to deliver complex care, but to allow them to focus on the task in hand.
And on the right is just one of the simulations that we undertook probably quite early on. And again, it's just reiterating that under a high pressure environment, you want the staff to feel comfortable with what they're doing.
So that's probably it for us for just now. We'll probably stop there, and we're more than happy to engage in questions and answers at the appropriate time. And thank you again so much to everybody, and again to thank all our colleagues here at Alfred Health for their support.
Thank you for having us.
Thank you so much. That was just so, it's just such a powerful, I know it's a short seminar, but I think it's a very, very powerful seminar, listening to, what you've actually had to deal with. And thank you so much for sharing this with us. One of the things I've always known is that wound care is a multidisciplinary approach and that we get better outcomes. COVID has shown us just how important that multidisciplinary, supportive, collaborative approach is. And in particular, to have that managerial support and to also have that support when, you know people are frightened, people want to come in and do the best work that they can, but we need to support them to be able to do that. And you've given us a really lovely overview of how Alfred has done that. I'm not sure whether the bedside guide is available to Monash Health Partners. I'm not quite sure whether anybody has done anything like that, but it just looks like a very, very useful thing. So what I'd like to do now is open up to questions. At the moment, I don't have any questions on chat, and I'm just wondering, would it be easier if people, whoever wanted to ask a question, and we have gone a little bit over time, but there was no way that I wanted to stop either Michelle or you, Padraig and Grace, talking, because that's the essence of what we're doing today. So maybe, but just, put your hand. I'm not quite sure how you want to do it, but because we've actually only got 10 minutes, I'm happy for you to put a question onto the chat board and I can read that, or other people can look at it, or just unmute yourselves and just tell us who you are and ask your question of the people who you're asking. Thank you. You're all going to be shy now, aren't you? Oh, here we go. Not a question. Okay. But thank you to all the teams. As a paramedic, we don't get to see this side of patients' treatment. Paramedic in Darwin. Thank you so much, Zeb. That's a really lovely comment, and it goes to the clinicians that have been graceful enough to share their experiences with us today. What I might do is, until I get another question here, I might just ask of you is just to please let us know before the close of this Zoom, just on the chat forums, if that's easiest, if this seminar was useful to you. So Zeb shared that with us, and also whether it would be useful for you in the future, perhaps every second month or every month, whatever you feel would be useful to you, whether you'd like us to facilitate regular seminars in this sort of pressure injury space. So just think about that and feel free to let us know, please.
Carolina, it's Michelle here. I've got a question for the Alfred ICU team. Thank you so much for sharing your slides and your experience with us. I'm really interested in how you went about coping with the number of patients you had come through ICU with the spike you recently had in Victoria, and in terms of staffing and teaching everyone. How was it that you coped? Because I guess for us, we had just a 2-month period and then it was over. But how did you go about teaching all your staff, everyone being on the same page? I'm just really interested to know, because I could see it would have been a big strain on the resources.
Yeah, thank you so much for your question. I think multifaceted approach. We had strong organizational support. It's probably also worth mentioning, like many organizations, while we were dealing with the work in hand, many organizations like us were also envisaging many more patients. So we were also trying to improve and increase capacity. So essentially trying to manage a rapid expansion in capacity, but also a rapid expansion in the complex patients that you were seeing at that time. So I think an organizational approach to, I suppose, backfill more junior staff and increase the capacity and skill of some of the staff that you have. Interestingly, for us, particularly in the second period of time, we were in lockdown. So staff actually wanted to come to work. Coming to work for them was, yes, a difficult environment to come to with many challenges, but in many respects, a positive thing. They could come and see their colleagues, albeit in PPE, but it was often a nicer experience than being in lockdown at home. So rather than potentially a fatigue management issue, it was really about anxiety management. And
we also tried to increase our normal streams of communication that we would normally have. And so we started staff forums and really tried to engage with staff almost on a constant level, I think, as a leadership team.
Yeah, and we can't overemphasize, I've mentioned already about, our senior leadership engagement, but that one-to-one real personal leadership in person, day to day, listening to concerns, giving solutions in real time, that's tremendously powerful. And I absolutely appreciate that every organization would aim to do so, but the power of that really is demonstrated during such an event as this.
And I think it's demonstrated by the fact we didn't have any healthcare worker infections. We really worked hard to get the basics right.
Oh, thank you
Well,
so
congratulations on your work. It's absolutely brilliant, and thank you for sharing it with us.
Thank you so much, Padraig and Grace. I've got a question for you, Michelle.